Thank you very much for having me. Myself and Don Melnick are going to talk a little bit about what's happening around personalized education. I'm going to start with the lens of kind of what's happening through accreditation. Thank you, Dr. John Norsini, for setting that part up. And then talk a little bit about some of the theories that are supplying that. These are my disclosures. So the outline is, I'm just going to give you a quick overview again. I think we've heard a lot this morning, so I won't spend a lot of time, but I want to connect a couple things we heard this morning. Then I'm going to talk a little bit about some key learning theories that really underpin concept-based medical education. I think are really important for personalized learning, and I think are finally finding their way into medical education. And then I'll talk a little bit about what are the implications for the individual learner, but also what are the implications for a system to support the individual learner through their developmental trajectory. So you heard a lot this morning from Dr. Zhao about the Frank report. I strongly recommend this is reading the Lancet 2010, looking at the global health education training. And one of the figures that I really like from that article kind of contrasts the traditional model we've been in for almost 100 years, really catalyzed by Flexner in the United States back in 1910. But really highlighting the point that Dr. Zhao brought out, that really what's changed is instead of starting with the curriculum or what we think is important, among a group of experts, really starting with what the health and healthcare needs are of systems. That's the starting point. And then, and only then, do you really develop the competency and outcomes to meet those needs. Now, some of those will overlap globally and some will be local. All right, so we heard that global-local theme earlier. And then after that, you develop the curriculum and assessment. And I think that's a really important theme. They're the last things you do in this evolution. Now, the only thing I don't like about this slide is that it's projected as though curriculum and assessment are separate activities. I believe that they're actually tightly integrated, and I'll come back to that theme. With regard to the outcomes, I think the ultimate outcomes of education actually relate to the patient. This is a model we're using in the United States. Again, it was alluded to earlier this morning. We call this the triple aim, where you look at the experience, that's the quality and safety aspects of patient care. These are the 6 Institute of Medicine's aims for quality. Then you worry about per capita cost in the health population. Obviously, with regards to health and cost, the United States doesn't do very well in international comparisons. We don't do so great on some of the other quality comparisons either. So you have to ask yourself, why do we have this misalignment between our medical education system and the outcomes that we know are really important? And I think it's always good to go back and look at a definition. This is a definition of competency-based medical education that was developed by an international group and led by Jason Frank of the Royal College of Canada. And I think it's simple, but I think it highlights a couple important points. It is an outcomes-based approach, and one of the really important things that it's in the guise of a program, right? Not just a single intervention, but truly a program that uses an organizing framework of competencies. And the unit of progression is mastery. All right, of the specific knowledge and skills or competencies needed for practice within the region in which you're going to provide care. I think what's important to note here is that the word mastery. A lot of times competency-based medical education gets confused as we're just shooting for competence, that all we care about is the floor. Couldn't be anything different than that. What we're really shooting for is mastery, because that's what our populations deserve. So let's take a quick look at some key learning theories. And I just, full disclosure, I am not the expert here. You have some experts in the room. Kelly Skeff and Georgette Stratos are 2 that come to mind that I know are here, and they can tell you a lot more about these. But I think they're important because they really revolve around experiential learning. So the first is David Kolb's experiential learning cycle that highlights how important our concrete experience is in our learning activity, that through observation and reflection, forming abstract concepts, and then testing those in new situations are critical to our developmental growth. And that has to occur, again, in the context of actual experience. And so when you move into graduate medical education in particular, and then in continuous professional development, this is mostly what you do, right? You should be learning through your experience. The other thing that's getting a lot of attention are these socio-cultural theories. And I think that's really worth highlighting those because they've kind of not gotten enough, in my view, attention in medical education until this point. The first I would just point out is that subject matter and learning processes are not uniform. They're as diverse as the people that are actually participating in the program. That's a fundamental underlying principle of these socio-cultural theories. Second, the learning is highly influenced by the social milieu in which it occurs. We're learning more and more that context, where you actually get your training, matters a lot. In fact, within the last 6 months, there have been 2 studies in the United States that have shown that if you train in an institution that is providing higher cost care, then you're more likely yourself to go out and provide higher cost care and actually do worse on a certification exam if the right answer on the test is do nothing or do less. And that's just a factor of the environment. So 2 separate studies that have shown that in the last 6 months. So the milieu matters a lot. And learning is situated in the context where it occurs. And so what that means is the subject matter, content, and process are inseparable, right? They're integrated. And we have to consider that. And that's why integrating this into the health system, again, another theme from this morning, is absolutely essential. Because that environment and that system matters a lot, not only for the patients that we care for, but also for learning. The other theory that's gotten a lot of attention in the competency-based movement is Anders Ericsson and others' work on deliberate practice. And he points out that to receive maximal benefit from the feedback involved in deliberate practice, individuals have to monitor their training with full concentration, and that training is effortful and it limits the duration of training that occur in any given time. It's interesting, in Anders' work, what he found was that most people at best could go for 5 to 7 hours and they'd take a break. Some would even nap. As you can imagine, in medicine, that's a tough sell. And Anders pointed out that this deliberate practice model, where you really focus on tasks, you keep getting better at it, will lead to expertise over time. The other thing he pointed out is really important is that you have to have professional teachers and coaches. You cannot do this in isolation. You have to have people there helping you. And again, in the United States, there was a nice article in the New Yorker by a surgeon by the name of Atul Gawande, who noticed that his performance had actually plateaued. And he wasn't quite sure why that happened. So he invited a former surgical mentor into the operating room to help him. And as he said in that article, that one 20-minute conversation had given him more to think about that he'd had in the last 5 years from every other source. And what was interesting about that, it wasn't just the holistic part of it. The advice he got from that mentor was, you're not standing at the right place around the table. You know, when you're using that piece of equipment, your elbow's not in quite right position. Pointing out how important coaching and observation is, even throughout our career. Yet we tend not to do it in medicine. And this is actually where I think the pilot analogy does hold. Pilots get observed all the time. They have check rides, they go into a simulator, their data is downloaded on a regular basis. Once we finish graduate medical education, we're rarely observed. Rarely ever observed, providing care or getting feedback from a colleague. The other model that's heavily influenced us in the States is the Dreyfus brothers developmental model, where you move through these stages. They did a lot of work in various fields, including the military back in the 70s and 80s, to figure out how people move through these stages. Now, we all know that people don't move in a straight line. They will go up and down. There may be some progression, and there may be a regression. And it's why it's important to keep checking in through this process. And nobody's trajectory looks exactly the same. So that person in green, we would not want to hold back. If they're moving at a faster pace, why would you want to have them doing the same thing over and over again? We know that actually stunts learning. It's not good for them. And that person on the red line, they're not going to make it. And the best thing we can do is get them into something else. And the earlier, the better. And so these developmental models, hopefully by doing these check-ins more routinely, might be able to help us with that. So how might assessment system, milestones, and entrustable professional activities help us get to better outcomes? These are things that we're now beginning to use. And this, in some sense, has become one of our disruptive, hopefully, innovations. So let me just take a minute to talk about what the professional self-regulatory system looks like in the United States. And I want to really highlight 2 kind of key actors in this that are going to probably we need to rethink their roles. First and foremost are the residents. Up until now, evaluation assessment is something we've done to them instead of something we do with them. That's going to have to change. So I'll talk about in a minute. Residents have to be co-producers and co-creators of both their learning and assessment. All right, they have to be active agents in this system. We also know they have a combination of assessments to really determine if they've met, the kind of outcomes of interest. We're now defining through milestones. And what I show here in red is that a lot of those observations, assessments are going to occur through tools on the ground embedded in the health systems and the places where they work. It's not that simulation exams are important, they are, but the richest source of information on an ongoing basis for feedback has to occur in the context of providing care and working the system on a daily basis through observations, audit and feedback, multi-source feedback, patient experience, patient-reported outcomes. While I think the measures aren't quite up to snuff, I think this is where the world's going. And I could just as easily put into this a practicing physician who's going to also need to have this sort of information increasingly embedded in their daily practice. And then for us, we're using a committee process, another big change to the system, because we know from group theory that if you do this well, you actually make better entrustment decisions. The other thing for us on the right-hand side, I'll be perfectly frank, has been a bit uncomfortable. The accreditation certification, had actually had a pretty bright line between them. They no longer do. We're figuring that relationship out. We're now using very similar data to make determinations. And so that's really changing the dynamic in the way that we work with each other. So what about learners in a CBME program? As I said, learners must be active agents. Here are the implications. As I said, they have to co-create and co-produce their own learning. And that means that we have to prepare them to be self-directed assessment seekers, right? They have to be comfortable going out and saying, like, hey, I'm not really comfortable doing that shoulder exam. Can you come watch me do that, right? And they have to learn the concepts and the skills of informed self-assessment. We're learning how to do that now, and there are tools. In our country, the MedEd certification program actually has some very nice tools to help people do that informed self-assessment process. And then they're going to have to be partners in designing their educational experiences. Again, another shift. This personalized learning means we need to activate them to move, a lot of their learning forward. And so how can we get to better outcomes by really helping and assisting the learners in training programs? This is what we're trying to do through the current accreditation certification process. For one, this past year and a half, we implemented something called Milestones. Milestones are just a significant point in development. And they're meant to be checkpoints, a time where you sit down and you talk about in aggregate and synthesize assessment information and say, how's this individual doing? And you hope that the milestones enable both the learner and the training program to make sure that that learner's on the right trajectory, that when we launch them out into unsupervised practice, they're truly ready. And so by having these touch points, for us, we use, as I said, this clinical competency committee. That's one of the big changes, that when you get to the end, you feel like you've reached a reasonable point so that they're ready to keep that trajectory moving upward. The other concept's getting a lot of attention on the Entrustable professional activities. This is a concept developed by Ola ten Cate out of the Netherlands. What I really like about this concept is entrustment, and you can see what this means. The practitioners demonstrate the necessary knowledge, skills, and attitudes to be trusted to perform this activity without supervision. That's the ultimate entrustment a training program has to make. When they leave you, are they ready to continue that upward journey? And hopefully this will help us get at what I call the ballistic model of competence, where we hope we launch somebody so high up into orbit that they're retired before they burn up on reentry. I think that's what we're trying to avoid. And this is how we might put the system together, and this is what's happening in some programs. We took these competencies, which are hard to make sense of. They've been in place since 2001, and we broke them apart. We analyzed to understand. Analysis actually means to break apart. And for many of our communities, this was actually a very useful activity. You always worry about reductionism, but what's interesting for me, having been involved in the internal medicine milestones, it's the first time the community had ever had a conversation about what they wanted an internist to look like at the end, among 390 plus programs. And then you can put those back together to have those important activities, such as lead a healthcare team, manage patients with chronic illness, participate in quality and patient safety activities using the milestones as building blocks. And so in essence, the milestones and EPAs for us have become a roadmap. We know the journey is not a straight line. We know there's more than one path, getting back to that personalized learning. And milestones, we hope, will enable us to get there. And it also helps us avoid the problem, if you don't know where you're going, any road will get you there. And so in the end, what we're hoping these milestones will help us do is to better align and integrate the curriculum and assessment. This is in the context of GME, but I would make the same argument that practicing physicians need to have an aligned curriculum and assessment too, embedded in what they do and integrated with the health system where they work. I think that's where we're headed. Yep, the measurement's messy. It's not nearly as good as some of the stuff we have, but that's where we got to go. So I'm going to stop there and turn it over to Don, and then I think we'll take questions.